The first speaker is Hyun-soo Lee. He is from Korea University Medical Center. His topic is 12-lead ECG predict the site of origin of idiopathic ventricular arrhythmia. Welcome.
Okay, thank you. Thank you, Chairman. It's a great honor to have this opportunity. So, okay. 12-lead ECG remain a valuable mapping tool for the determination of ventricular arrhythmia origin. As well known, the 12-lead ECG supports a lot of information to us. 12-lead ECG is the initial mapping tool to predict the most likely site of origin, and it's valuable to choose the appropriate ablation strategy. The most important ECG features are like this for the ventricular arrhythmia localization: QRS axis, bundle branch block pattern, precordial transition, and QRS width and morphology. The QRS axis has both vertical and horizontal, superior, inferior, and right and left dimensions. The vertical dimension is reflected by QRS polarity in lead 2, 3. For example, the all outflow tract ventricular arrhythmia share an inferior directed QRS axis with the positive force in the lead 2, 3. The horizontal dimension is better reflected by lead 1. The structure close to the left side will produce a deep negative the complex in the lead 1. Conversely, the structure close to the right side a strong positive in lead 1. In case of the RV-OT, the anterior and posterior can be distinguished by lead 1. Anatomically, just underneath of the chest is the RV free wall, so the anterior part is slightly right side and the opposite is the posterior. Therefore, posterior origin is the positive at lead 1 and anterior origin is negative. Next, the bundle branch block morphology means the other chamber origin. The ventricular arrhythmia with the RBBB morphology typically arise in LV, while the ventricular arrhythmia with the LBBB morphology may arise anywhere in RV, but also in the left side of the interventricular septum. As a result, the bundle branch block patterns can be used to determine whether the right or left ventricular origin. Usually, V3 to 6 is positive in the base, but go down to the apex, it becomes negative. The precordial transition in RBBB ventricular arrhythmia, the predominant S wave occurs progressively earlier as move from the base toward the apex of the LV. The LBBB ventricular arrhythmia, the precordial transition occurs progressively later as move from the septum toward the RV free wall. Also, regarding the transition, this study is simple qualitative measure of PVC, the precordial transition. When the PVC transition occurs later than sinus rhythm, an LVOT origin could be excluded with 100% accuracy. In the case of LVOT origin, the transition at or earlier than the sinus rhythm was around 71%. Therefore, PVC, the transition later than sinus rhythm, effectively rule out an LVOT origin. And they measure the V2 transition ratio also. V2 transition ratio greater than the 0.6, predict an LVOT origin with the 95% sensitivity and 100% the specificity. Summary of this study is the PVC precordial transition occurring later than sinus rhythm, excluded on LVOT origin, and V2 transition ratio significantly greater for the LVOT PVCs. Next is the QRS width and morphology. The height of R wave in lead 2 at the septal site was significantly taller than the free wall. Likewise, the duration of R wave in the lead 2 at the free wall was significantly wider than the septal side. This study analyzed the ECG morphology and the precordial transition of pacemap and the clinical arrhythmia between the septal and the free wall. This is the result. In the pacemap, the iris free wall notching of R wave in inferior lead is 95%, and the late precordial transition is also 95%. In the clinical arrhythmia, the notching in inferior lead is around 86%, and late precordial transition is also 86%. As a result, notching in inferior lead and the precordial transition, late precordial transition can distinguish between the septal and the free wall. To summarize the comprehensive anatomy approach for the prediction of site of origin, we start looking at the superior inferior axis represented by polarity in lead 2-3. Next step is separate from the right or left side of the chest midline, which does not necessarily mean the RV versus LV, especially in the outflow tract where there is a significant overlap between RVOT and LVOT. And the bundle branch block pattern can be used to determine whether the right or left ventricular origin. The precordial transition can help to distinguish right or left ventricular origin, and also early or late precordial transition. QRS width and morphology can possible to distinguish between the free wall and the septum. I'd like to briefly introduce ILVT. The Purkinje-related monomorphic VT can be classified into 4 distinct groups: fascicular VT, bundle branch entry, interfascicular, and focal Purkinje VT. And there are 3 subtypes of fascicular VT: left posterior fascicular VT, and anterior fascicular, and the upper septal VT. As well known, the most common form is the left posterior fascicular VT. This is the typical ECG morphology of ILVT. The posterior fascicular VT is RVVB with the left superior axis. The anterior fascicular VT is also RVVB, wide inferior axis. Upper septal VT is narrow QRS, normal or right axis deviation. And then usually LV has 2 stout papillary muscle, anterolateral and posteromedial. Anterolateral papillary muscle VT often has RVVB with the inferior axis, which is similar to the left anterior fascicular VT. And lead 2 AVF has the positive or biphagic. However, lead 3 is mostly positive. The posterior, the papillary muscle VT has also RVVB with the superior axis. Is very similar to the left posterior fascicular VT. The left posterior area VT is the most common. It has very similar ECG characteristics between left posterior fascicular VT and the posterior papillary muscle VT. Although the distinguishing arrhythmia from the papillary muscle and Purkinje tissue is challenging, an attempt should be made because the technique used in ablations are different. The QRS width and QRS morphology in V1s are not sufficient to distinguish these 2 tachycardia. However, the presence of Q wave in lead laterally 1 and AVL may discriminate the posterior fascicle from the papillary muscle. The Q wave indicates only left to the right septal depolarization during the left posterior fascicular VT. However, the posterior papillary muscle is slightly more lateral structure than posterior fascicle, and the septal depolarization occurs later in the QRS, hence the absence of Q wave in the lateral lead. Therefore, early and late septal depolarization can distinguish between these 2 tachycardia. This is another study. This study compared the electrocardiographic and electrophysiological parameter between 2 groups. Papillary muscle VT is longer QRS duration than the left posterior fascicular VT, and the conduction duration from the earliest left ventricular activation site to the proximal right bundle branch was longer in the papillary muscle VT. This is the result. QRS duration is less than 133, 100% the left posterior fascicular VT, and the longer than 133 measure the early-stage activation to the right bundle branch. It was less than 36, mostly posterior fascicular VT, more than 36, 100% the papillary muscle. Now we can distinguish the left posterior from the papillary muscle VT by these two techniques. Okay. The ECG localization has several considerations, such as the replacement and body habitus and shift in the relationship of heart to the chest wall. Okay. ECG analysis might help for the catheter ablation procedure, especially the ventricular arrhythmia. Thank you for your attention.
Thank you. Your good presentation. Have any question for our audience? Speaker is very clear to us how to differentiate the right side VT and the left side VT. But I curious the question. Recently, many AI very popular in the world. How, in your opinion, maybe the ECG, the diagnostic by the AI is suitable or is okay in your opinion? Or in your test lab have also have the development the AI for the ECG diagnostic?
Yes, I agree. But I think one important thing is the individual. I mean the heart shape is different, position is slightly different, depending on the patient. That's why I think that's the one of the issue.
Okay, thank you. Have any question? Okay.
Hi. Did I get it right that you said the absence of Q waves in lead 1 helps to rule out papillary muscle? Is that the same with S waves in lead 1, or is it doesn't really include that? S waves in lead 1 as well as Q waves. Does that help, or if there's S waves present?
Actually, I never think about the S wave.
Yeah. Okay. Yeah. I just wondered. Thank you.
I was thinking in the lab, usually you would use 3D mapping, right? But your ECG, because of the 3D mapping patches, you might not be able to put exactly where it would be.
Yeah.
So would you compromise on the mapping or the electrode?
Actually, we localized not inside the lab. The before we watching the ECG first, and then they localize first, and then doing the procedure. Compare like that.
Before radiofrequency catheter ablation for VPC, VPs often disappear suddenly. It's many times. How do you do in this situation? You give some drug to induce the arrhythmia, or stop the procedure, or how to do?
We do everything. Sometimes smoking, and drinking some coke or coffee. Yes, provocation. One of the provocations.
Some VPs occur from the epicardial portion, such as every summit. It's too poorly eliminated. It's too difficult to compare the other VPC. How to do for poorly eliminate the epicardial VPC, endocardial approach or epicardial? I know that your ladies have a lot of experience with the epicardial.
Usually, I think endocardial may first, and then move to epicardial. How about you?
In our lab, we occur epicardial cases, and we try to insert it into the coronary sinus deep. It's too unstable of the impedance. It's not comfortable. So usually we do endocardially approach for treating the left summit VPC. It's not popular, not many in our lab.
Actually, you mean the AIV, like AIV, anti-ventricular arrhythmia, it's very difficult to assess, and then when deliver the energy, impedance is too high, cannot. You same experience?
Okay,
you have?
yeah, I totally agree with that.
So, I would like to ask you one thing.
No.
So, how can you become an ECG master?
Okay. Okay. ECG master. Drinking with the expert colleague every day. Thank you.